Hi, I'm Martha Terris. I'm one of the trustees of the American Board of Urology. I'm going to talk to you today about the complications narrative. This is some paperwork that you do along with your logs that you submit, either for initial certification or as part of lifelong learning. Currently, the timing of that is about year 7 into your cycle. Although there are some changes in the American Board of Medical Specialties that may change that long term, but now in 2020, this is what the timing is. So your complications narratives should include any Clavien 3, 4, or 5 complications that you had during the time, that 6-month time of your case log. So we don't need to know about blood transfusions. We don't need to know about prolonged ileus requiring TPN. Those are Clavien 1s and 2s. But Clavien 3 is a trip back to the OR. So stent placement, for example, if you have a Steinstrasse, that would be something you'd need to report. Clavien 4 is a trip to the ICU for organ failure, renal failure, a stroke, a heart attack, something like that. And of course, Clavien 5 is death. You also should report in your initial certification any perioperative deaths, that's within 30 days after surgery, since you started practice, and in the lifelong learning cycle, any deaths you had during the past 10 years. So, if you didn't have any complications, which would be unusual, but some people don't, we still need a statement saying that you didn't have any complications, as well as have you complete the part where it says whether your hospital has a root cause analysis of major events and whether you attend a morbidity and mortality conference at your facility. As far as the narrative itself, you start off with the patient identification, what the complication was, what the surgery was, and what Clavien grade the complication was. We want just the clinical story there. And most of us have an electronic medical record. You can cut and paste that story from your discharge summary, your operative note. But please include what consultations you've gotten, what preoperative testing you obtained, to see if, so we can see that you were thinking about preventing complications. During the hospitalization, if you consulted general surgery or cardiology or someone like that, tell us about that, even if it's not necessarily in that discharge summary. And then finally, the last portion of that is your summary of maybe what you've learned. And that's really the most important part. We're really unimpressed if you just put, oh, the patient was old and sick, too bad, too sad. I mean, that's not, that you didn't learn anything from that. But, for example, if you had sepsis requiring an ICU admission after a prostate biopsy, we want you to talk about your antibiotic choice, talk about other options such as rectal swabs or perineal biopsies or a postoperative MI. Talk about whether you got a preoperative cardiology consultation and clearance for that patient. So we really want to know that you're thinking about preventing this complication occurring again in the future. Of course, some of you have practices that are going to have a high rate of complications, an oncology-heavy practice where you're doing a lot of cystectomies. We know that the reoperation rate, the readmission rate for those is higher than most cases, and we take that into account. Thank you very much. Good luck.